24-hour series. It gives me great pleasure to introduce Ken Hunt, who's going to be talking about the management of syndesmotic injuries. We see so many of this, Ken, in the athletic population, somewhat also in the non-athletic population. So I'm curious to hear how this is going to go. We want to thank Acumed for sponsoring tonight's this session. Thanks.
Well, thanks, Selene. I really appreciate your inviting us to be a part of this. It's really been great so far, and we look forward to contributing. As Selene mentioned, we're going to talk today about the management of syndesmotic injuries, and we'll really focus on the ligamentous injuries that occur in the athlete. This is the 8 o'clock time zone mountain time. So mountain time for those around the world is kind of right in the middle, left of middle of the country. So I'm coming from Denver, Colorado. What the mountain zone is known for is skiing, largely. Dr. Clanton, who I'll introduce in a moment, is in Vail, Colorado. Skiing certainly gives lots of opportunity for recreation and opportunity for ankle injuries. So it definitely keeps us busy managing what we're going to talk about. So it's really a pleasure and an honor to welcome Tom Clanton, Pieter and Norm Waldrop. So I selected these gentlemen because each has an expertise and interest and really a passion in management of syndesmotic injuries. So I want to thank each of you for being here. I look forward to learning from you and getting insights into how to manage these problems. So syndesmotic injuries, we're all familiar with these. These are the external rotation injuries of the ankle. It happens if you catch a tip skiing. It happens if you plant your foot and externally rotate on the sports field. So we know that the ligaments that get injured are the AITFL and PITFL, the interosseous ligament and membrane, and the deltoid ligament. So that's what our focus is going to be primarily on the ligamentous injuries. So this is a case-based conference, so I'm going to just dive right in here. This is one of my cases. This is a 21-year-old lineman for our college football team. He was on the field. He suffered an external rotation injury and kind of limped off. So we got X-rays. The stadium we're at gave us the ability to have X-rays, and his exam was consistent with a high ankle sprain. So Norm, I'm going to start with you. What are your first thoughts on deciding whether an athlete with an X-ray like this is going to be able to return to play?
Well, the first thing that I want to know is can he walk and can he push off? And you say that he's unable to ambulate. So once I have my X-rays, initially I want a good set of weight-bearing X-rays. And so is the ankle mortise congruent? What does the medial clear space look like? Has the tib fib overlap changed? And I love a contralateral comparison view, something to compare the other side to. And then certainly a stress X-ray is something that I'd be looking forward to next.
Yeah. So what we find at stadiums, and this may not be true where you are, but where I work, most stadiums don't have the technology to do weight-bearing X-rays. But stress X-ray are definitely possible. So we did that, and this is what it looked like. What do you think?
Well, you can see here on his initial X-ray and then his stress X-ray, there's a pretty significant difference, right? So you could be lulled to sleep with his initial X-rays, but given the clinical suspicion that you had, his stress X-rays is significantly positive. That medial clear space is you could drive a truck through that. So that's concerning to me.
Yeah, so concerning for a deltoid injury, and he certainly clinically wasn't able to get back to play. So got back to campus, got this MRI, injured deltoid, injured interosseous membrane and ligament, and both anterior and posterior ligaments are out. So this was a late stage. So we decided to take him for fixation. This was his intraoperative stress, which confirmed what we'd seen on the sideline. Tom, when you think about how you're going to approach this is a purely ligamentous injury. What's your go-to? What type of device do you use? A plate? How many devices? Configuration? Kind of what's your approach? You're muted there, buddy. Tom, you're muted if you can hear me. I don't want to miss out on the brilliance. All right, there you go.
So what I would probably do is examine them again carefully under anesthesia. I tend to arthroscope these syndesmosis injuries. There's a high incidence of articular cartilage injury. And so I want to be certain what the articular cartilage looks like. I think you can do it either arthroscopically or you could do it through an open visualization of the joint, and then maybe putting a small scope in to look through the open incision. You can do it either way. But I think you must determine if there's articular cartilage injury, because that's been associated with poor outcomes from these types of injuries. Once I've determined that everything looks okay in the joint, I do look at the syndesmosis, and I usually put in a probe there and see how far up I can extend the probe. Sometimes you can take it up past the interosseous membrane and into the area of the higher level. So you know you've got to get very good fixation. I think in some cases you can do this with flexible fixation. I think that in other cases, using rigid fixation with screws or screws through a plate is reasonable. And then sometimes using hybrid fixation, which would use a screw through a plate as well as flexible fixation like a tightrope through the plate. And then you have the option of removing the screw and still have flexible fixation left there. Then I would retest after that fixation and determine just what is going on with the deltoid. I think in this situation, it looks to me like it would be a case where I would repair the deltoid. The other alternative would be immobilizing it for a period of time in neutral. Sometimes that works very effectively, but I would probably stress it after putting in the lateral fixation and then see what things look like after I've stabilized it with 2 tight ropes like you've done here.
That's perfect. That's a very thoughtful approach. And you brought up a really good point. I will scope all of these for the reasons you mentioned, identifying articular injury and assessing the deltoid. So Pieter, I'm curious, when you see these pure ligamentous injuries and you're repairing them, how often do you repair the deltoid and what are your indications for it?
Yeah, thanks. And good morning, Chris, Norm, and Tom, and the whole audience. When we talk about the deltoid, it's an ongoing non-consensus situation, especially in these isolated cases where there's no combined fracture. However, there's 2 reasons why I would go for a deltoid repair. First of all, is that you see about 11% of syndesmotic injury related impingements afterwards, where we all put some steroids or some sort of injections in because there's some remaining synovial irritation after fixation. And because of that, you can have it anterolateral, but you can also have it medial in the gutter. So if there's some irritation there, you want to avoid that at all stakes because you had your surgery already. Therefore, I joined the discussion saying that we would do it through an arthroscopic approach, see how it feels like, see where the tissue is, and because of that, repair the deltoid afterwards when there is too much signs of possible irritation there. The second one is that you have in a medial approach of problems, you really can how should I say, you have that medial pillar that you want to protect, right? Now we know from the studies from fractures that there's no need to repair the deltoid, but we are talking not on a sedentary or recreational athlete population. We're talking about competitive athletes. So we just want to make sure that it's a one shot for all and that we don't have remaining problems after. And especially, we don't want to reconstruct what we could have repaired afterwards because the results there are much less. So in summary, just to make sure we have a good sleep and just to make sure that our patient doesn't need a second arthroscopic cleaning up. For that reason, I would go for the deltoid in this particular case to review it under arthroscopy and decide when to repair it there.
Excellent. Yeah, very thoughtful, and I completely agree with that approach. So this young man was able to get back in 8 weeks. I'm about to be told that that's a really slow recovery process. but he was able to play in our postseason game and played another season and had no issues with his ankle subsequently. So we're going to go to the second case. This is one of Norm's cases. Similar story. Offensive lineman goes down, difficulty weight bearing, X-rays negative for fracture, pretty clear deltoid injury. Norm, why don't you kind of take us through this case and your thought process as you made decisions for treating this player?
Sure. So this was an offensive lineman. It was, as he said, rolled up on during the game. He had a player fall into his planted foot, was down and unable to ambulate. We had to help him off the field, evaluated him in the locker room, and he fit many of the criteria that I look for, which are inability or difficulty normally ambulating. He had tenderness that extended greater than 5 centimeters above the joint. And if you look at some of the literature out of West Point back in the early 90s, that 5 centimeter cutoff in terms of level of tenderness tends to be sort of that critical number when you're looking at a significant injury. So this extended well above that up into the leg, which is concerning. A positive mid-shaft fibular squeeze, which is very important. So they hurt at the ankle, not where you squeeze them. So given all of that, we elect to get an MRI. Now, typically at the University of Alabama, if you have a hangnail, you get an MRI. So that's a little different than the normal criteria. But since he did fit in that bucket, we get an MRI. And one of the things that I have, you can see this on the image on the right side of the screen, is that my syndesmotic protocol for MRI extends further up into the leg. So my sagittal cuts go higher than the normal ankle x-ray, which allow me to see how high that fluid is getting up the interosseous membrane. So you can see here on the image on the left, he's clearly got an AITFL injury anteriorly, and then posteriorly, he's got a PITFL injury off the back, fluids escaping out of the back of the ankle. And then on the right, on that sagittal image, on the axial image, you can see that fluid is extending well up the leg, and there's no connection there with that interosseous membrane. So that's a very concerning MRI to me.
So then stress view shows, similar pattern, clear deltoid injury. So this is an unstable syndesmosis. This is minimum stage 2B. And so you took him to the OR, and see if I can get rid of my laser pointer here.
I did, and if you can get this video to play here on the left, this is sort of the typical arthroscopy that I'll see with these athletes. And this is the posterior lateral view with me looking posterior laterally, and you can see the PITFL here where it's attached is clearly pulled off the posterior lateral tibia. And this is sort of the classic look. You see this nearly every time. And what I'm doing back here is sort of cleaning up that avulsed piece of cartilage that you'll often see and trying to give this area sort of a rough plate to, or rough area to stick to. So not only am I trying to assess the arthroscopically assess the cartilage damage, clean up the impingement lesions that Pieter talked about, clean up the interosseous membrane. I also think the lavage of the joint is very important from a pain standpoint. So I'm trying to do all of that with my scope. And then you can see go ahead, Ken.
Oh, sorry, I would make your last point. Go ahead.
And so you can see here the image on the right is my typical technique of fixation. And you say here, why the use of the plate? So I typically use a plate, unlike the image that you showed earlier. And this is really, the plate itself is really for force dissipation. So I use the plate as a way to spread out my forces over the fibula. So as I typically will use 2 tight ropes, try to slightly diverge them as you showed in your images earlier. They were very well placed with my most distal tightrope about 1.5 centimeters above the joint line. And so one of my greatest fears in allowing athletes to return to play at an expedited rate is fracture of the fibula. And so the plate is meant to dissipate those forces, and so that button doesn't concentrate that force over your drill hole. And so that is the reasoning behind using a plate.
So great point. So I want to talk a little bit about rehab, and Norm, I'm going to have you go through your rehab plan. But first, I want to ask Tom, since you trained Norm, what's your for a lineman that's been treated for this? What's your kind of standard, return timeline? Like what are your parameters for return? Oh, your mute button stuck.
First of all, I'd say Norm learned very well. And I'd say that in these injuries, if you can stabilize them adequately, then I think my rehab was always 2 weeks just to let the soft tissues heal. I didn't want to have a wound breakdown, and so that was one of the things that I thought was really important. And then at that point, we tried to start motion and then begin partial weight bearing, progressing to full weight bearing as the patient was able to do. I think Norm's pushed that along a little bit, and I think as long as you've got a stable situation, there's nothing wrong with doing that. And obviously, it's worked very well for University of Alabama players.
So, and I know Norm, you had him back in practice at 10 days. He passed his 15 single leg hop test at day 12. Maybe you can just comment on this video. You're muted, bud. Sorry. Muted commentator.
Sorry. This is him, number 76 on the right. Can you show that again? You can see if it'll roll through. He's our right tackle. And as you recall, it's his left ankle. So this is him playing about 2 weeks out from surgery, and so certainly it's very controversial in terms of allowing an athlete to go back at that. So we try to use very guided, very specific, very objective data when we're doing so. So one of the things that we use is GPS tracking. So all our players at Alabama, and we've been collecting data now for 6 years, use some of these wearable technology devices that allow us to collect a pretty significant amount of data. So there's a lot of data that you can collect. Well, we've tried to sort of cone that down from the medical standpoint, not from the player performance standpoint, into certain things that we can do. We're looking at, what is their workload, what is their velocity, their change of direction, acceleration, deceleration, and all kinds of different data in helping us guide their rehabilitation. So one of the advantages that we have is that we can compare their data post-injury to all their data pre-injury. And so we'll get a good idea. So in this particular athlete, so he had injured his left ankle, if you recall. And so one of the things that I'll look at for them is one, their acceleration, their ability to push off, and their ability to change direction. And so in doing so, in particular for him, I'm looking at how he changes direction, pushing off, moving to his right, which is it, because this is his left ankle. And you can see here initially he struggles to do so, but as he gets close and at his game day where he returned, he was back to his preoperative levels. And so that gives us a good feeling as he's getting into practice and getting closer to return that we have a player that can approach and or 90+% what he was preoperatively. And in most cases that allows us to feel that he is safe to return.
That's perfect. And can you just quickly run through the highlights of your post-op protocol? I think it's unique, and you've had great success with it, and I think it'd be valuable for this audience. So maybe in 2 minutes or less, run through it.
So I used to splint them, and so I've stopped splinting these the athletes after surgery. I actually put them in a compressive dressing, and then in PACU, I will place them in a cold compression device, whatever your choice is. And so I will give them an IV NSAID or IM, depending on usually Toradol for 2 doses postoperatively, and then I'll begin an NSAID postoperative day 1. I do keep them non-weight bearing for the first 4 days. And so that's to keep the soft tissues quiet, but swelling control is absolutely critical. I've found that that's the #1 factor in limiting the athlete's ability to return. So at postoperative day 4, if everything looks okay with their wound, we'll change their dressing, and then we'll start physical therapy with a focus on range of motion and swelling control. Once we get them through that and they're comfortable weight bearing, we'll put them on the Alter G. And so the Alter G, which is the anti-gravity treadmill, it allows us to look at their gait. You can see in the image on the far right, what I'm looking at is, are they using an equal stride, or are they putting a symmetric gait on their injured side and their non-injured side? And if so, without excess external rotation, meaning they're trying to splint their ankle, I'll feel comfortable putting them on the ground as quickly as they feel like. And so typically we'll begin on land activities sometime in day 8 to 10, and we'll begin weaning them out of the boot as they feel like it. As they can get out of it, we'll progress them into an ASO brace and a regular shoe and start those balance and proprioceptive exercises, which are critical. All the while, that swelling control remains critical. If you've maintained good swelling control, they'll get their range of motion. If they get their range of motion, they feel comfortable running. If they feel comfortable running, they can get their strength back. And by doing that, if they're pain-free, you can put them through their return to play testing. So if they can pass the single leg hop test, which is not validated, and then if they can do that, I will put them through Dr. Clanton's validated return to sport test, which is a fantastic tool, which I think he may hopefully touch on for us. And if they can pass that, and they have the GPS data that backs up that they're similar to their pre-operative levels, I'll clear the athlete. And I don't do it based on time. It could be 2 weeks, it could be 4 weeks, it could be 6 weeks. I don't put a timeline on it. I use all this objective data, and whenever they can fit those criteria, I'll let them go. And if they're going quickly, I don't slow them down. And I think that's one of the things that I've kind of learned over doing this, is that I let them go at their own pace.
So Norm, that's a great overview of your protocol, and it's interesting to see how that has evolved even in the last 10 years. Coincident, I think, with how the techniques have evolved. Tom, I would be curious briefly if you can maybe share the resource for your validated return to sport test. I imagine many listening would be curious to see that. And you guys go ahead and unmute. You can stay unmuted unless there's a lot of chaos at your house.
So there are a number of different tests that have been validated. So there's a Y balance test. It just requires a specific instrument to use, but that has been validated. A jump test for height, a shuttle run where they go backwards, they shuttle to one side, run forward, go backwards, shuttle to the other side, run forward. That's been used as a validated test in several situations, and we've used it in some of our athletes as well. So I think that we're currently doing a systematic review on return to performance, and we've got some other things that will come out with that article that I think will be very interesting, and I just am not ready to divulge all of that just yet.
So Ken, we've got a bunch of questions, if I can intervene for a few things.
You may.
How do you stress, and how much pressure or torque do you apply to the ankle when you stress it?
Pieter, maybe you can take that one. When you're getting a stress image, how do you determine how much force to apply, and do you measure it?
You mean on a stress X-ray?
Yeah, on a stress X-ray.
Yeah, well, we have the tendency here, so I'll be happy to reply on that question immediately, but we have the look, listen, feel approach here, where with a non-invasive kind of tool have been validating that and have been trying to deliver to know whether an ankle would be stable or unstable without severe stress testing. Because of course, stress testing is possible, but our athletes, they kick our head when we do that. So of course you can do it in an anesthesia type of way. However, the personality types that we are dealing with do not like us to perform stress tests. So we had to find another way to deal with that. And I'm happy to indulge during the 1 hour privilege we have today to join in on that. But in essence, what it is you reproduce the external rotation of the ankle, and the stress test you put on is the apprehension that you get. So it's always different. And of course, if you have a patient that allows for it, I would do it in a sort of setting where radiology fluoroscopy in a private room, and then just do your type of cotton test for the medial side and your external rotation test, and see if you can open it up or not. You had 2 previous beautiful pictures of stress testing on X-ray. So a fluoroscopic dynamic approach with the right information towards the patient and for the right reasons. If you're unsure about your look, listen, feel, through clinical exam, through evaluation of the training video or the match video, and through your imaging modality. If you're not that sure yet, then I think with a shared decision making with the patient, we could go for it and do a stress X-ray, and then just the torque that you put on is just stabilizing the tibia, going for that external rotation and type of lateral translation, and then hope you have no apprehension before you need to know what you need to know.
Yeah, and I find it's much easier to get that right after the injury. Like, yeah, you know, at the stadium or at the practice facility before it really swells up, they tolerate a lot more.
And I totally agree with Norm that the swelling is really, really crucial. That's what we feel as well.
And Norm, you got a comment?
You have a great study that was, I believe it was your 2015 FAS study, you know, where you refer to widening being the last thing that we worry about, right? So we've showed these other X-rays that have medial clear space widening or, you know, shift. Do you feel like you can adequately manage or measure the posterior anterior fibular translation, which is that dynamic instability that we worry about before you see that medial clear space widening, which is an unstable syndesmosis in my mind, but you don't see it real well sometimes on that stress. What do you think about that?
Yeah, I completely agree with what you said, and that particularly applies to the grade 2 injury that doesn't have a complete deltoid injury, but has clear instability laterally. You know, because of the way an X-ray works and the fact that the fibula tends to translate posterolaterally, not just widen. Stress views are really challenging to interpret unless it's a complete injury like we showed in the first 2 cases. Then it's obvious. But for those more subtle injuries, I don't think X-ray is adequate, at least not in my hands, for the majority of them. And MRI is a useful tool.
I don't think that fluoro works as well either, Ken, in some of those subtle cases. And in a high-level athlete, I think sometimes when it's a critical situation that you've got to know, that's where you get your MRI. And usually from the MRI, you can get a pretty clear picture of which components of the syndesmosis are torn.
Yeah, we've written up a biomechanical study addressing this very issue, how what's happening kinematically is not what we're seeing on X-ray until it's a complete injury. So if it's a complete injury, you can see it, and if it's not, fluoro and plain films are just not enough. Seal, was there another question?
Yeah, there are a few here. So how are you guys fixing the deltoid?
I do an arthroscopic repair. I use one of the available arthroscopic kits that's designed for Brostrom, but I use that to repair the deltoid. I don't like doing an arthrotomy. I don't like opening it up, and that tool is adequate to get a repair. Peter, how are you repairing the deltoid?
Yeah, so normally I do a mini open because I want to see the more broad spectrum of it all the way towards the posterior side, and there I can identify my tip post and just go for a relief of the medial gutter and bring it up or bring it down. I normally in athletes don't augment with anything else at that stage, but that's probably your next question.
Well, Norm and Tom, anything different in terms of technique?
I'm slightly different. I do a mini open, but I tend to cheat it anteriorly because if you look at the studies, the anterior deltoid tends to be the first portion to go as it extends posteriorly. So I'll slightly cheat it anteriorly if I'm using an open approach to make sure I get a good repair of that anterior side, because that tends to be the most affected.
Right.
Yes, I do something very similar to both Norm and Peter. I'll use a mini open incision. I try to see the extent of the tear. Usually the anterior medial capsule is completely torn off bone. And so I'll also anchor that back with a suture anchor. And then the superficial anterior ligament, which is the tibio-navicular and the tibio-spring portion, and then the deep anterior, if that's present, are usually torn also. And so I'll usually try to repair those and then treat it with some degree of immobilization for a period of time for the potential injury to the posterior deltoid, although that doesn't happen all the time.
Quickly, Norm, does your protocol change when you repair the deltoid?
Absolutely. So if I fix the deltoid, I typically slow them down by 2 weeks. So I usually will splint the deltoid patients, those athletes, for about 10 days or so. And then I keep them off of it for usually about another week. So it ends up being about 14 to 17 days slower. But once I start, I put them through the same protocol.
All right, Selene, hit us.
Yeah, that was one of the questions actually you hit on, Ken. And then the last question is, as I have right now, is do you have a role in what ankle protection is applied during rehab? And what's the medical intent of the ASO during rehab?
What was the last part about the ASO?
What's the medical intent of using an ASO during rehab?
So Tom, the two questions there. One is what devices do you use during rehab, and what's the medical intent, or I guess the intended purpose of an ASO brace?
So using a brace postoperatively gives the patient a little more sense of protection of their ankle. And so they're definitely more comfortable doing things. I think Norm would probably agree with that when they have that feeling around the ankle. Athletes usually will be taped, and that works pretty well also, gives them some proprioceptive feedback. And then as they gain confidence, then we can gradually take them out of that. I use a brace pretty much full time at first, even, in a college athlete, walking to campus, after he's several weeks out, I'll have him still use the brace walking to campus. And then once he becomes more confident, then the brace is used less and less.
Okay. Yeah, I would be in agreement with that. I'm a fan of the brace over a boot for lots of reasons. It allows some motion, it allows them to walk at the same height, gives them some compression. So yeah, I would agree with that. All right, let's move on to cases. So this next case is one I took care of in my at my old institution. So this was one of our running backs, and during a tackle, you see that right foot, it plants, it externally rotates, and the opposing player at the conclusion sort of helps it along a little bit. I'm out of that rivalry now, so I can't make comments. But this was the injury. So he had tenderness of the syndesmosis, pain with external rotation. He didn't have a lot of instability, and he was able to do a heel rise. So didn't go back to that game. We got an MRI, anterior ligament out. Posterior ligament, they had a little bit intact. Deltoid, not bad. Not a complete injury. Definitely some strain there, but we saw fibers that were intact. So, Pieter, how do you expect to manage this? I know it's hard not having your own exam because that's a big part of it. But stress views negative, not unstable, injured the anterior ligaments, tweaked the posterior and deltoid. How would you manage it?
Yeah, so I mean, we already discussed a little bit how we're approaching this. However, we feel we go for the look, listen, feel, just to make sure. I mean, the real question is it stable or unstable, right? You're a bit in between there, and you have the posterior fiber still attached on MRI, but what are they doing functionally? Because we know it's not just an open book, it's an external rotation tibial sagging injury. So my question would be, how do I know if it's stable or not? Because that directs my whole further treatment. So the look, listen, feel. First of all, we've seen the mechanism, so the listen is there, and we have that external rotation. We have to say it because for the audience as well. But this, we have to get away from the word sprain. It has nothing to do with a sprain. It's a rotational injury. We call it a pivot. We call it the ACL of the ankle. Why? Because it has nothing to do with a sprain. It's an external rotation, dorsiflexion mostly injury, where the sprains are inversion, plantar flexion. But let's not go in there. The question is, how do we manage that? So we look at the mechanism, then we know already what we're talking about. We look at the two things. First of all, is there any radiation up during clinical exam? Like we discussed already, if you have that radiation coming from anterolateral distal all the way up over 3, 4, 5 centimeter, preferably 5, well, that's a sign that you have to ring the alarm bells. And that's our sign for clinical exam. And of course, the key to that lateral injury is medial. We have to palpate medial and have a feel of what's going on. And then that feel can be combined with the classic tests we have, the external rotation test, the squeeze test, the Clanton test, the fibular translation test. But mainly, I would say radiation up, medial, mechanism, and positive external rotation test.
Excellent.
Don't forget to palpate the proximal fibula, just for the records, that we have a complete setup. And how do we manage that? Well, once we know whether it's stable or not, we know if we have to go for some more invasive stuff or not. And then indeed, I do the same. We tape them, we brace them. We normally don't really boot them for the reason that the patients, as Norm has shown with his fast track rehab protocol, they can easily go straight forward into running, into dorsiplantar flexion when you manage the swelling. However, in our experience, the rotation is always the key to know when to progress, because that's where it sometimes differs between personality, between a season timeline, and between type of sports. You have your guys with helmets on, fully padded, but our little football players are ballerinas who jump from the field after every blow and whisper in the ear. So it's all about that type of patient that you manage, and I think there's of course not only geographical but especially sports specific differences in that.
Yeah, those are outstanding points. And now to be forthright, I took care of this athlete about 9 years ago, which seems like eons ago in terms of how we manage syndesmotic injuries. So I'm wondering, so we treated him non-operatively. He actually started 3 weeks later and played the rest of the season. So Norm, if I had thrown a couple of suture buttons in him, could I have gotten him back sooner?
No,
So Ken, let me ask a question if I can.
Yeah.
Would you now call this a 2B injury?
I would have called it a 2A because the posterior ligaments and the deltoid are intact.
I would agree.
Okay, right. And now would you treat that with PRP?
Yes, absolutely.
Yeah.
So I was going to ask that same question about PRP. So I think that's a great question. So Ken, I think one, if you on his physical exam, I think one very key component is his ability to do a heel rise. And so I think that is one of the separators that I use. I didn't mention that earlier, but they're an athlete's ability or inability to do a single leg heel rise in conjunction with all these other things is very important. So, in these 2A getting into 2B, deeper 2B injuries where you get in this sort of internal struggle about to fix or not to fix, it's all about the whole, not just one specific thing. But I do think there are some things that are more important. The 5 centimeters, the tenderness 5 centimeters above the joint. But I think that single leg heel rise is a very key component. The ones that have that dynamic instability, in particular that posterior translation to the fibula, really struggle with getting off the ground with that single leg heel rise. And his ability to do I don't think I've ever operated on a patient who could do a single leg heel rise.
I totally go ahead.
And so I get this asked all the time, unfortunately, where a coach will say, well, why don't you fix it? And I say, well, coach, if he can play in 3 or 4 weeks without surgery, that's better than being able to play in 3 to 4 weeks with surgery, right?
Yeah. And I'll say briefly, I've heard you say, Norm, and I really like this, that if you have a 2B or a grade 3 injury and you can turn it into a grade 1 injury, it should recover like a grade 1 injury. And that's kind of the goal of stabilizing it, not to make it perfect, but to put it in a position where it can heal as a lower grade injury, which is why you're able to accelerate. The point about PRP is a good one. And my comment is all anecdote. For all of our sprains, our syndesmotic injuries that are not unstable, we'll use PRP, and we get 3 to 4 in a season for each of our football teams. I'm a believer in it. Anecdotally, it looks great. We still need to publish the data and ideally do a comparative study, but I'm a believer in that technology. So we're going to move on to the next case. This is one of Dr. Clanton's cases. This was a baseball player. So Tom, I'd love to have you kind of talk us through this case. I'm going to start with the video.
So this is a baseball player. He's just hit a home run to win the game. He's going to round third base and come and jump on home plate. And unfortunately, he lands on one of his other teammates' foot and really twists his ankle badly. He obviously can't walk on it. And he has a fracture with a syndesmosis injury, as you see here. PR4 or SCR4 Weber C fracture. And so he was treated surgically at the time. And I absolutely can't say anything negatively about the way it was fixed. I think they did a great job with it. Unfortunately, a year later, he's still having problems and is unable to play. And so we saw him at a year later after he had missed the remainder of the season. And so he couldn't go back to play the next year. So we had these x-rays, and you could see that there was an osteochondral lesion on his talus. Want to go back to that? Okay, so he has this medial osteochondral lesion. So our idea was to go in and do something to fix that, and then determine if there was anything else we needed to do, like taking out hardware and try to get him out of pain. So we arthroscoped his joint to start with, and so his x-rays and CT showed this large osteochondral lesion with a cystic area. And when I arthroscoped the joint, he had a very stiff ankle, and there was obviously some arthropfibrosis there, but he also had this huge osteochondral lesion that was sitting in the joint and had been there for a year. And so that's one of the points that I thought we should bring out is articular cartilage injuries are common in both fractures as well as syndesmosis injuries. And however you do it, you need, whether it's direct visualization or it's arthroscopic visualization, it's really important to confirm that you don't have a bad cartilage injury in the weight-bearing part of the joint. We ended up treating this with a cancellous bone graft to the cystic area. The cartilage fragment we sent to Genzyme in case we might need to do an ACI on him later. Fortunately, we never had to do anything additionally, and he continued to play and actually did quite well and got a World Series ring. He returned to play after missing the 2011 season. So he'd missed 2 seasons, so very unusual to get somebody back to play at that point. But he was a very motivated individual. He played 8 more seasons, and he even won the award as best designated hitter one year.
That's a great case and a great result. Norm, I'm curious, when you see those cartilage injuries, and I agree, a good number of these patients have some level of cartilage injury on the lateral talar dome. Are you doing anything acutely other than removing the fragment? Is there a role for microfracture or acute cartilage grafts?
So I no longer microfracture these. I'm concerned about intra-articular pressures and actually creating a larger cyst, especially when it's a shear type injury and you don't have a large bony component. So I typically will remove the fragment. I actually will take my burr and just score the bone just to create a roughened surface. But I no longer microfracture.
Okay. Selene, question?
Yeah, you got it. 2 of them. And they kind of, one goes back to the deltoid. When you guys do your repair and you use anchors, are you putting those anchors in the tibia or the talus?
I always put them in the tibia. That seems to be where the sleeve avulses from the tibia. What does the rest of the group think?
Yes.
Medial malleolus, anterior colliculus.
Yep. And the last one is, are any of you using the suture-based bracing technologies to reinforce the AITFL in your syndesmotic injuries? And if you do it, when do you decide to do it?
Tom, you want to take that one?
Okay. Well, we have a study that is just about to go for publication related to that in a cadaver study biomechanically. And it definitely seems to show that augmenting the AITFL can help restore stability in an injured AITFL. That tissue quite often is not easily repaired. And so I think that there's definitely some benefit in putting a suture tape augmentation over the top of it if you need more stability.
Yeah, so I've used that primarily in chronic situations where I don't have enough confidence that the ligament will heal appropriately, but I'm definitely watching with keen interest, Tom, the data from your lab, and I know you have other studies ongoing. Once I think we identify as close to normal pathophysiology as possible, I think that's probably where it will migrate for fixation, similar to what's happened in the ACL. Next case is one of Pieter's. So Pieter, maybe you can take us through this case and then I can guide some discussion points.
And before you do that, one other quick question that just
go
came
ahead, Selene.
regarding the microfracture. Is everybody on the panel no longer microfracturing, or are some of you guys still doing it, but with smaller awls? What's the consensus on the panel here?
So for acute injuries in syndesmosis, for example, I don't microfracture. There's already a sort of a macrofracture environment, so I want to remove the mechanical fragment and make sure that it's stable, but I don't do any bone marrow stimulation because it's already, we have a macrofracture. So in kind of chronic osteochondral lesions, I've gone away from microfracture. I do drilling. It's less traumatic and it accomplishes the same goal. but I don't macrofracture for reasons that have been mentioned. Worried about cysts, it's a little more traumatic, it's a little more painful. Normal, what do you have to say?
I'm in agreement. For the trauma, for the fracture, for the syndesmosis, where you already have a bloody traumatic environment, I do not. And for the acute and chronic, if there's a cystic component, I don't even microfracture the cysts anymore because I'm into the softer bone of the cyst. So it's fairly rare that I will do so. And then when I do, I like you, Ken, I drill. I do not use the awls anymore.
Okay, Peter, take us through this case.
So this is a case of an athlete that was treated 2 years before presenting with the current injury, with a distal fibular fracture, treated, operated elsewhere, no problem at all, perfect recovery, played for 2 years, and then suffered from a new left dominant acute trauma with pain anterolateral with effusion and presenting at us 5 weeks after the injury.
So Tom, quickly, what do you think about that X-ray? Do you see anything concerning?
Well, I think definitely you've got widening of the medial clear space. If this, I'm assuming that this was done as an AP X-ray, and it doesn't look like there's very much tibiofibular overlap. So I would say there's probably been a syndesmosis injury as well.
Okay, so there's the long leg view.
Yep.
So in summary, you have a player here that was treated 2 years ago for a so-called simple distal fibular fracture, plate and screwed, played well, with a sudden syndesmotic injury 5 weeks ago, inability to play with all the signs that we discussed previously. And by doing a proper clinical examination, you evaluate the proximal fibula and you see that there's a meson fracture. So here we are with indeed all the signs of a new syndesmotic injury. And that's for the moment where we are, Ken.
So, so Norm, at this point, it looks like this is a little bit displaced. The fibula looks a little bit short distally. Is there a role for repairing a proximal fibula fracture, a Masonov variety fracture?
So I've gotten to where I'll go pretty high. I don't know if I would go that high, but I'll certainly go mid shaft to getting into that proximal third. I think it is vitally important to control the length of the fibula, because when you see these go poorly, you'll see fibular shortening, you'll see the talus fall into valgus. And so I think it's very important to control the length of the fibula. So I'll go to, I will go up high, may not go that high, but I'll go up high, even if it's just to put a single screw in to control that length.
Yeah, and rotation, right? You want to get the rotation right too. So Tom, as you're looking at this and you're planning to fix the syndesmosis, if there's a Masonov injury, do you change the implants that you use? Are you still comfortable using flexible implants, or is this where you'd go to a more of an internal brace type of an implant?
Well, if I have a link stable, non-rotated Masonov, then I will use standard flexible fixation. And I've done that and it's been successful. If it is not a link stable type of fracture, I'll tend to follow Dave Thordarson's advice about fixing it proximally. I think in that situation, if you are comfortable working around the common perineal nerve in that location, and you know how to release the fascia there and decompress the nerve, then you can do that and fix it with a small plate, get it reduced and plated, anatomically reduced. if the surgeon that's doing the ankle is not comfortable working around that area, then they need to get their knee partner or friend to come in and do the exposure, and then they can put the plate and screws in.
Yeah, great point. So Peter, tell us what you did and how this athlete did.
Yeah, so the thing with this player is that he didn't want any other surgery after this one. So you can say we'll put screws in and then maybe remove them. We might remove the plate afterwards. But what we intended to do is give him his one-shot treatment, meaning removing the plate, getting it right, getting that rotation on the distal part, that alignment in the best way we can. We did it under arthroscopic control and then used 2 suture buttons to hold it after minimal clamping. We for sure don't want to over constrain it as well. However, we did choose to put 2 for the mesonerve reason. If we have a deltoid rupture, or we have let's say a posterior malleolar avulsion or fracture, or we have a mesonerve, we always put 2.
Great. So last question, then we'll wrap up. Norm, when you're doing flexible fixation like this, and you want to judge the rotation, the width, the length, how are you doing that? Are you doing it radiographically? Are you doing it arthroscopically? How do you know when you've got the right rotation?
So combination. I think arthroscopically you can stick the scope in there very easily, as we've talked about scoping. So it's already there. You can stick your scope in. I think one of the most underrated parts of this, which people have not talked about, is the lateral view. I think getting a good lateral x-ray and making sure your fibula is appropriately positioned on the lateral x-ray when you get good overlap of the 2 portions of the dome gives you a really good idea that you have your fibula in the appropriate position. We tend to focus on the AP and the mortise views, but I think the lateral is very key. And that's probably the most important x-ray, in my opinion, when you're trying to get that final rotational portion dialed in.
Yeah. Listen, you guys are brilliant. Thanks for being a part of this. I learned a lot. I appreciate it. Selene, I'll hand it back to you.
Yeah, thanks you guys for a fantastic panel. Ken, this is a stimulating topic that you guys know we don't have all the answers for yet. And glad to see that I'm doing a lot of things you guys are talking about. So appreciate it. Thanks to Acumen for sponsoring this session, and we'll see you at the next session.
Okay. Bye, everybody.
Thank you.
Thanks, everyone.
You, and thanks again.